after the sorry, after the eye-opening lecture from two experts, my lecture will be the blend of these two lectures, but I mainly focus on the pain generators. Discs in spine, disc is the main culprit. So I will focus on the discs, pain generators, and its management by the full endoscopic system. So endoscopic surgery can be divided into three groups. One is endoscopic assisted, other one is uniportal, and the next one is biportal. The lecture which you have heard by two experts is mainly the uniportal one they talk about. But there is another technique, this biportal technique, and there is endoscopic assisted technique. Okay, in endoscopic assisted technique, it's a tubular technique, but there is a equipment camera system, but it doesn't uses any water flow. In uniportal system, we have only one portal, working portal, so it's called uni. But in biportal, as you see in the picture, oh, it has two portal. One is for the scope and other for the working. Whereas in uniportal, you have the scope and the working channel in the from the same scope. So it's uni and biportal according to the number of the portals. So when we call the endoscopic spine surgery the true percutaneous endoscopic spine surgery, because to be the true percutaneous endoscopic spine surgery, we need to have the spinal surgery that is done percutaneously with a stab incision with full endoscopic system, and that utilizes soft tissue dilation rather than cutting technique. So it helps to lessen the soft tissue trauma, and it helps to fasten the early rehabilitation, and it use the constant saline irrigation. So the endoscopic assisted system like tubular system or Destandu system, they are not the true percutaneous endoscopic system, though they are endoscopic assisted system. Already the advantage of the endoscopic system has been elaborated, but I will just want to summarize by saying that the operating time, as you matured, as you learn the endoscopic system, the operating time which is shorter, there is a less blood loss, and there is a less post-operative pain, and we can have the faster post-operative rehabilitation, and the hospital stay of the patient will be shortened, and the patient can return to work faster. In spine, like in Dennis column, pain generators can be divided into three columns. This the anterior column, middle column, and posterior column. In anterior column, the pain arises from the discal pressure change, whereas in the middle column, the pain arises either from the neural structure or there is a change in the chemical things. In the posterior column, the pain arises from the somatic derangement. So it consists of the facet joint, it has the muscles, ligaments, and it has the innervation also. So if by the posterior column dysfunction, the deep somatic derangement, we may have the pain generator in the posterior part. So in the middle part, we have neural and chemical change, and in the anterior part is mainly due to the change in the discal pressure. So what is this? We know that it's important structure. When pathological, it can be associated with low back pain with or without radiating or referred pain, and discogenic back pain, and pain due to prolapsed discs, herniated discs, and pain due to stenosis is commonly encountered in our daily practice. Disc has two layers: inner nucleus pulposus, which is avascular and annular, and outer the nucleus pulposus is surrounded by the annulus fibrosus. It has also two layers, and in upper caudal and the cranial part, we have two end cartilages, end plates. So it attaches, the disc attaches to that end plates, because end plates has the value for the spinal pain. So this is the structure of the disc in short, and disc in a homeostasis by the balance of the mastocytic production stimulator and the mastocytic production inhibitor, and the breakdown of the matrix by the different biologics, this bone morphogenic proteins, BMP7, growth representation factor 5, transformation growth factor beta, and insulin growth factor. These are the stimulator. Whereas interleukin 1 and tumor necrosis factor alpha is an inhibitor, mass inhibitor, and the metalloproteinase they breaks the matrix. So by the formation breakdown, so there is a constant homostasis. But when homeostasis is broken, then they will start the problem in the spine. And the disc is innervated posteriorly, laterally with a sinovertebral nerve. And the sinovertebral nerve is a bridge connection, like a bridge. It connects the spinal nerves to the sympathetic nerves here. And this sinovertebral nerve has also connection with the ventral and dorsal ramus. So the spinal nerve and the sinovertebral nerve, they work together to assist in the segmental dysfunction. So when there is a dysfunction in the segment, we'll have the problem in spine. So I will come later on this part. So, and the end plates are innervated by the basivertebral nerve. So it has also connection with the sinovertebral nerve. So it's like a network of the nerve that will be found in the spine. That is the pain generators. And when the pathological discs, symptomatic discs are studied histologically, it is found that though the nucleus pulposus is avascular or neural, but when it is pathological, symptomatical, it is found that there is an ingrowth of the vascular granulation tissue along the tear of the annulus into the nucleus pulposus. Not only the vascular tissue, but it has also been shown that there is a growth of the neural tissue inside the nucleus pulposus. When there is a growth of the vessels and the nerve, these are the stimulant for the pain in the spine. And it is also found that when these pathological discs were studied, it is also found that substance P, vasoactive peptide, neurofilament, these are the pain markers. They were found abundantly in the painful discs than in the control discs. And it is also found that there is a massive expression of growth factors like basic fibroblast growth factor, transforming growth factor beta, connective tissue growth factor in the painful discs. When there is just a disc degeneration, but there is no pain symptoms, there is found that there is no nerve growth, there is no formation of vascular granulation, and only the expression of only a few growth factors. So we have to differentiate between the symptomatic and asymptomatic discs. Every degenerative disc may not be the symptomatic at all. It may be the asymptomatic. So it's a challenge to differentiate between these two. But there are some methodologies that is be utilized to find the painful disc. How the pain is produced in the discogenic back pain. The initial insult is there is a change in internal disc derangement. And this internal derangement leads to the internal disc tear. So that there is an ingrowth of the nerves and vessels. So that stimulates the sinovertebral nerve and basivertebral nerve that we talk about. And there will be the activation of pain substances. So that ultimately lead to the back pain. So this is the pathophysiology of the discogenic back pain. And what about the pathophysiology of this prolapse disc or lumbar disc herniation? The same insult, first insult is there is an internal disc derangement and there is an internal disc tear. Then there will be a herniation. And there will be an ingrowth of the nerve and vessel like in the discogenic back pain by the stimulation of the sinovertebral nerve, basivertebral nerve, and plus there will be activation of the pain substances, and on top of that there will be a mechanical pressure over the root. So there will be a back pain, low back pain, and radiating type of pain. And when you talk about the spinal stenosis pathophysiology, the first insult is the same. There is an internal disc derangement, and that leads to the internal disc tear, and that tear leads to the segmental dysfunction in all three columns that I described: anterior column, middle column, and posterior column. That leads to the stenosis by the bony hypertrophy, ligamental flavum hypertrophy, and slackening of the discs. So the upper migration of this superior articular process that impedes the foramina. So because of that, there will be the ingrowth of the nerves and vessel that leads to the stimulation of sinovertebral nerve, basivertebral nerve, activation of the pain substances, mechanical pressure of the root and cord, so that ultimately lead to the low back pain, claudication, and or radiating pain. This is the pathophysiology of the spinal stenosis. So let's talk one by one how this is treated endoscopically. Discogenic back pain. Discogenic back pain can be divided into two parts. One, the pain arises from the annulus, that is annular disruption induced low back pain, and other from the end plate disruption. One is from the sinovertebral nerve, other one is for the basivertebral nerve. Now we have, this discogenic back pain can be managed by percutaneous full endoscopic technique that we call this transforaminal epidural laser ablation TELA. This is ablation of the sinovertebral and basivertebral nerve, and this is the promising percutaneous endoscopic technique. Prior treatment method of discogenic back pain has less favorable outcome and has less problem. And this is the paper that we have published together with Professor Kim on sinovertebral nerve. And this is the paper we published together with Nitin, Farid, and Professor. This is on the ablation of the basivertebral nerve. So the result by the ablation of the basivertebral nerve is 93%, whereas the ablation of the sinovertebral nerve can produce 96% good to excellent result. Now the prolapse disc, lumbar disc herniation also can be managed by percutaneous full endoscopic system. Once this cauda-equina syndrome, spinal stenosis, recurrent disc herniation, stable spondylolisthesis, calcified disc, once these are considered contraindicated for the endoscopic surgery, is now no more contraindication for the endoscopic surgery, because we have now paper that describe that all type of lumbar disc herniation can be done by the endoscopic methods with a 96% good to excellent result. And we can clarify, we can grade and score the difficulty of the surgery, of the endoscopic surgery of discectomy by the table, and we can also grade as seen in this table, and we can get the more information about this these two tables in the pain physician. You can note this one. An endoscopic approach can be transforaminal, interlaminar, transpedicular, and others. When this endoscopic transforaminal discectomy can be divided into in and out and in approach. In and out approach, we approach the disc directly inserting the instrument into the disc itself. But whereas in out and in approach, we do not go inside the disc. We remain outside and we target the pathology and we do the discectomy. The difference is that because of the big range of the instrument that we insert into the disc, the recurrence rate after the discectomy is most probably higher in and out approach than out and in approach. But depending on the pathology, we can use both approach. But nowadays there is a shift that the transforaminal endoscopic approach is shifting from inside out to outside in technique. And this transforaminal endoscopic discectomy can be done through the three routes. One is exiting route approach, other is intervertebral approach, and other is suprapedicular approach. This far lateral discs, foraminal discs, superior migratory disc herniation, they can be approached by exiting route approach. Whereas this paracentral, central, mild inferior migrated, high canal compromised discs, they can approach through the intervertebral route approach. And the suprapedicular approach is utilized for high-grade inferior migrated disc. Similarly, interlaminar approach, discectomy, can be divided into two, this shoulder approach and the axillary approach, depending upon the pathology where it exists. And there are problems related to the discectomy by the endoscopic discectomy. In the problem is a high iliac crest, narrow foramen, migration, and recurrence. But there is already a solution for this problems. Like for a high iliac crest, there is a transiliac approach, or we can approach that pathology by interlaminar approach. And there is a solution for the narrow foramen. We can widen the foramens by the foraminoplasty technique, either by the reamer, burr, sealer, or by the technique is resection of the superior facet, superior vertebral notch approach, as SICOT, that's circumferential suprapedicular circumference opening technique. I will come this one later on. This foraminoplasty by this is utilized for highly migrated intracanal disc. And we can also use the superior vertebral notch approach by widening this foraminal approach by the reamers. And this SICOT, suprapedicular circumference opening technique, can be utilized for high-grade inferiorly migrated lumbar disc herniation. Once this migrated disc herniation was not amenable to treatment in the past, but now it is amenable to treatment because there is solution by the escort technique, suprapedicular technique, transpedicular technique, interlaminar technique. By use of rigid, flexible curve probes, we have foraminal bent approach, different approaches like the down level interlaminar approach and contralateral transforaminal approach. So we have techniques, we have instruments, and we have different methods to tackle these migrations. And there are a lot of literatures that suppose that the migration discs can be treated endoscopically. This is the SICOT technique. And we have the solution for the recurrence also. Recurrence of this is a big problem. This annular sealing and targeted discectomy by outside in technique is one of the method to reduce the recurrence. And other method is we can approach the discectomy by the anatomical approach, by the ligament fibrosis splitting approach, that is structural preparation. The study done by Hansen Kim he showed that in his study that when he had done annular sealing technique, the recurrence rate has dropped down from 13.5% to 5.5%. And when he added up with the ligamentum fibrosis splitting technique, that we call the structural preservation technique, it reduced from 5.5 to 2.5. So let's come to spinal stenosis treatment. This spinal stenosis can also be managed with percutaneous full endoscopic technique. And first we have described this percutaneous endoscopy stenotic lumbar technique, PESLD. This is the landmark paper for the decompression of the stenosis. The preliminary result of this technique was very encouraging. We could achieve 96% good to excellent result, and the procedure is safe. And this procedure does not widen the facet joint that you see here. The stenotic was widely open, is decompressed without violation of the facet joint here, and the soft tissues are preserved. And the post-operative MRI by the technique after this decompression, when we take the MRI, it shows that is a well decompressed stenosis. So there are emerging alternative endoscopic techniques against uniportal endoscopic technique we have to know, because I talk about the biportal also. So one of the technique is uniportal, biportal endoscopy. This we call it UBE. So there are systemic review which say that UBE may be feasible option for lumbar spinal surgery. When the UBE is compared with open lumbar microdiscectomy, it is found that a similar clinical outcome related to the pain control, functional disability, and patient satisfaction, with the further advantage of the endoscopic spine surgery with the UBE. And when there is a comparison study between UBE, uniportal, and microsurgery, the literature says that uniportal or biportal endoscopic lumbar approach may be effective for treatment of lumbar central stenosis and can be alternative to conventional neurosurgical decompression. So we can also utilize this technical UBE for the fusion. It's an alternative minimal image, can be more minimal invasive technique. So there are some extended indications of the endoscopic spine surgery is now being utilized other than disc herniation, stenosis, and discogenic back pain like fusion, discitis treatment, treatment of the Bartholdi syndrome, other problem in sporadic form, like in spinal tumor that we heard from the Jinseng Kim, in the geriatric patient, and also in the obese patient, we can utilize this technique, endoscopic technique. This spinal fusion still is the endoscopic spinal fusion is still in the evolving phase. We have three techniques, that is Indo-TLIF and biportal endoscopic lumbar intervertebral fusion technique, and we have transcamin Indo lumbar intervertebral fusion technique is evolving. And here this is already published data, that's Indo-TLIF, transcamin Indo-LIF, and also the biportal fusion technique are already in the literature now in the world. And we can also use this endoscope for the treatment of discitis. There are a lot of evidence available that the first paper in 2004, 13, is 14, and 15, and 18. And this also, when the percutaneous transfer endoscopic discectomy is used for the drainage of the spondylolischitis, the result is very positive outcome in early cases. So we can utilize endoscope for the discitis treatment as well. And we can also use the endoscopic method for the treatment of the Bartholdi syndrome that has been published by our team. And we see here that there is a Bartholdi problem here with the pseudo articulation here. It can be decompressed by the endoscopic technique. So it is feasible with the treatment of the Bartholdi syndrome with the endoscopic syndrome. And we have the remote future indication of the endoscopic for the spinal use is used in the disc regeneration. So we can use the endoscope as a visualization and delivery tool of biological materials. And if you want to learn more about the endoscopic procedures, you can refer this book, Endoscopic Procedure in Spine, edited by Jinsung Kim, Yunjo Lee, Yong An. And we have one chapter also here by our team, current limits and feasible future modification lumbar endoscopy. So my take-home message after this lecture is, as said by the Jinsung Kim, treatment of discogenic back pain, discectomy, stenosis decompression, and fusion will all be percutaneous full endoscopic in near future. And in due course of time, all spinal problem can be solved by percutaneous endoscopy technique. I'd like to acknowledge my mentor, Professor Hengsen Kim, for mentoring me in this spinal endoscopy. So I would like to I want to end my lecture here. Thank you, and I want to welcome to Nepal after the resolution of the COVID. Thank you.